My name's Cynthia Elford. I go by Cindy. I live in Hermitage, Pennsylvania, and was a very active person. I did a lot of catering for other people. I loved to vacation and just go all over the place. It was about 6 years ago when I went to Florida and I was down there for 3 months. In the meantime, while I was down there, I had progressively started walking the bridge, but I noticed that I was having a severe amount of pain. I kind of brushed it off because I've been a diabetic for many years since I was a child, and I just thought it was neuropathy.
Thank you for having me today. I'm Mehdi Shishabur. I'm the president of the Harrington Heart and Vascular Institute at University Hospitals here in Cleveland, Ohio. Well, we know that patients with CLTI, patients with critical limb ischemia or significant vascular disease that have ulcers and gangrene are on the rise. And this is kind of good news and bad news. It's good news because we've done very well with improving longevity. We have a lot of good medications. We have a lot of good operations that allow patients to live many years. But unfortunately, we also know that there is a rise of diabetes, there is a rise of obesity, there is a rise of chronic kidney disease, and these are the things that lead to CLTI. So not only we have seen a rise in CLTI here in Cleveland or greater Northeast Ohio, we've seen it across the country. Now in some areas there is much higher rise, let's say the tobacco belt. In some other areas it might not be as much. But definitely there's been a global rise, and actually we published this about a couple of years ago, showing that there's been a significant increase in the number of patients with CLTI or CLI, if you will. And these patients are very special patients because they have significant comorbidities. Many of them, over 70-80% have diabetes. Many of them have chronic kidney disease. Many of them are former smokers. And many of them may have prior amputations. Now, they may have been minor amputations, or they may have been major amputations, meaning that they have already lost one leg, and now they're coming with the other leg in trouble.
I love to sunbathe, so I was at the pool and I was there quite a bit, and I developed a sunburn on the tip of my toe. I couldn't get it to heal. I tried everything that you would do for a sunburn, and it wouldn't do anything. It wouldn't heal. I had an appointment with my endocrinologist, Dr. Nasser, up at the clinic. And when I told him about my walking and how the pain was, he told me he didn't feel that it was neuropathy. He said, Cindy, I think it's arterial disease. He said, I want you to see a specialist. So that's when I met Dr. Shishabor. What a guy. Love him. He did my angiogram on my leg. Well, after it was over, I guess he worked like 2 hours and there was no success. He tried and tried, and when he came out, he just kept saying, I'm so sorry. And I knew then that the leg had to come off. Well, they tried first by taking just part of my foot, and that wasn't so bad, but it wouldn't heal because the arteries were blocked from my ankle down into my foot. So they turned around, they took my the lower part of my leg off, it was a left BKA, below knee amputation. That was really tough. That was a hard thing to get through, but I managed. I ended up in the Sharon Hospital down here, in a facility to help me learn how to move and exercise and do all the things I needed to get home. So eventually I did. I got home and the leg healed up and I got set with a prosthetic.
I first met Cynthia about 5-6 years ago at my previous institution, and it was an interesting story at the time. She had a very small ulcer in her foot, in her toe. She was in a lot of pain. and she had seen one of our vascular surgeons who had evaluated her and had offered bypass. But when they had done the angiogram, they had noticed that there were no options in her foot. There were no targets for them to be able to do the bypass. They had attempted endovascular approach to try to open it percutaneously, but it was not successful. So they sent her to me as a second opinion.
I went to do a stupid thing. I decided I was going to clip my toenails on my foot that I still had. And when I did that, I took a tiny piece of skin away. And guess what? It didn't heal. It just kept getting bigger and bigger. And the toe, that was my second toe. My first toe, the large toe, it was starting to look a little brown on the toenail. But I never gave it any thought. But when I couldn't heal, I started worrying. So I got on the phone, called for Dr. Shishabor. At that point, I found out that he was now at University Hospital. So I made an appointment and I went up to see him, and he scheduled me for an angiogram. And I can remember him, we discussed in the room, and he was so sympathetic with me. I mean, he's just so compassionate. And I said to him, please, don't let me lose my leg. And he goes, we'll get through this, just like that. When I had my toes cut off, or when I had half my foot cut off, my foot didn't heal because I was only open down to my ankles. And then they had to take the below the knee amputation because otherwise I wouldn't heal. But with the below the knee, I had two places where the surgeon had tied the stitches off that just seemed like were never going to heal. And just those two spots. And then the one eventually healed. And then once the other one healed, I was able to go and be fitted for a prosthetic.
And, we have a lot of experience in treating patients like this, so I thought maybe I could open the vessels up using endovascular techniques. So I tried it actually twice in trying to help her, and I was not successful. And finally, after a lot of struggle, she ended up getting a below knee major amputation at that time. She did well for a couple years, and then most recently, about a couple years ago, she showed up again with the same exact scenario as the previous leg. A small ulcer on her toe, but very painful, which had required a toe amputation, but we knew that she did not have good blood flow. Same process. She went through vascular surgery. They looked at her angiogram and they said there were no targets. They sent her to me this time and they said, hey, do you think there is anything you can do? And I made an attempt at it. I was not successful. I didn't want to give up. I tried one more time. And as you know, losing both legs can be detrimental. As a matter of fact, losing one leg, those patients, 50% of them, they die by 2 years. Now losing both, you can just imagine, for a young woman like her, I think she was in her 50s at the time, it would have been huge. So at that time, we realized that maybe could there be another option for her.
When I found out that there wasn't anything I could do but have the amputation, after they had tried so many things, and it just came down to where I couldn't take the pain anymore. And it came to the point where I can remember falling back on the bed and my leg going up over me, And it was like I was so helpless and in so much pain that, I thought, how? Nobody should have to go through this. So, I made it through, but it was rough. It was really rough. Because before, I was somebody that was always out and about, traveling, and I loved boating, and we were paddle boating down at the Poconos. I mean, things like that, where you really use your legs, skiing, and just different things like that. And how I wouldn't be doing that again, or in my mind, I wouldn't be doing that again. So I was facing giving up everything that I loved, or in my mind, I was. When I found out then that I had to have, well, the other leg was probably going to be amputated. Well, it wasn't even probably. I knew it was going to be. When Dr. Shishabor had told me there wasn't anything he could do, and I laid there kind of numb, I didn't think I could do it. I mean, I was very sad, thinking that my life was pretty much over. And I didn't, at that point, feel that I didn't think I was going to be able to live, because I just couldn't bear the thought of not having either one of my legs. So getting through that was the hardest thing I ever did. But like I said, he works miracles, that man does. So, with that lymph flow, here I am today doing all the things I want to do.
Just then, I was building a relationship with LymphFlow, and we were enrolling patients into Promise One. So I reached out to LymphFlow and I said I want to enroll her into Promise One. But unfortunately, because of some of the strict rules that we have for clinical trials, and she had a condition called Churg-Strauss, which is a vasculitis, she was excluded. But the impact on her would have been so huge to lose both legs. The impact on her would have been so huge because she would have lost both legs. So we decided that, can we do a compassionate care? Can we do a compassionate care approach in her situation? So we reached out to LymphFlow, we reached out to FDA, we asked university hospitals, and all three organizations kind of came together and allowed us to do a compassionate care procedure in her. So we did the procedure at that time, and as you know, she still has her leg, her wounds have healed, and she's doing fantastic. Yeah, I think what's very important here in this situation is that the same patient 5 years ago, 6 years ago, we did not have the LymphFlow option, and we had exhausted all of our options in regards to open surgery and endovascular. And then you fast forward 2.5, 3 years, and she shows up with the same condition, but now we have a new option for us. We have an option for these kind of patients that cannot get open bypass, and endovascular has failed for them. And I think that the LymphFlow gave us the hope. And the hope was that this is a female, young patient, has no targets, we can't fix it percutaneously. Can we use LymphFlow to try to heal this wound? And that's why we offer the LymphFlow as a compassionate use care, and we were able to provide blood flow to her foot and allow her to heal her ulcers and still be able to walk as of today, 2 years later.
At that point, I was kind of numb because I didn't know, how it was going to be hard. And I couldn't imagine not having neither leg, I needed at least one of them. And all of a sudden, I heard these doors open and somebody going, Ms. Elford, I think I have something for you. And it was Dr. Shishabor, and he says, I think I have something that might work for you. And at that point, he said, just if you can hang on and deal with the pain, let's see if we can get this through. And that's all I needed for him to say that. And then it was after that, it was painful to wait, but I didn't want my leg cut off either. So I went and up to the clinic, and that's when I was presented with LymphFlow. And they explained it to me and how it would work, and I trusted this doctor with all my heart, so I went ahead with the LymphFlow. And I can remember being in the procedure room while they were doing this, and all of a sudden I heard people clapping their hands and screaming, just like so excited. And then Dr. Shishabor's nurse came to my side and she said, Cindy, he got it done. He did it. So I, at that point, felt that was it. I was going to have my leg. And he's been the most wonderful doctor in the world. And this LimFlow, it's just incredible. So with everything that I've been through, now I'm up and I'm walking and I'm, can do grocery shopping and do all the things that I couldn't do before. And it's helped me so much.
As you know, the LimFlow procedure is a little bit complicated because it's something new, it's something novel that we now have to treat our patients. And the way it works is that, and what we're trying to do, these are patients with significant arterial disease. As you know, there are two circulatory systems in the body. We have the arteries and we have the veins. The arteries have oxygenated blood, and they take the blood from the heart to the tissues, to the brain, to the gut, and to the legs. The venous system takes the deoxygenated blood, the blood that has been used already, and brings it back to the lungs to provide it oxygen. What we do with LimFlow is that because the arterial system is so blocked, there's so much traffic. That's the example I give my patients. Imagine you're going to the highway and there's so much traffic and you cannot get to the airport. You jump on the other side, opposite direction, and you just bypass the traffic. And that's what we're trying to do. So what we try to do is that go from the arteries into the veins and create arterialization, so make the veins become an artery per se, in quotation, and supply blood in that way to the foot, because we know that the veins don't have blockages. And by doing so, we are able to provide nutrients and blood and oxygen to the dead tissue and be able to save the limb. The procedure, I remember, took about 3-4 hours. It's kind of interesting because now we can do it in about 60 minutes to 90 minutes, depending on the complexity. But this was one of my first procedures. And I think the impact was huge because the bypass takes about 3-4 hours. By the time you bring the patient, you prep the patient, and you harvest the vein. So while, at the time I thought, wow, this takes so long, I've come to recognize the impact that it has on patients. If we can save a limb, it is definitely worth the time. I am certain that if Cynthia, at the time she came with her second leg, 2.5 years ago, she came and I tried endovascular procedure twice on her, that if we did not have LimFlow, she would have for sure ended up with below-knee amputation on that site. She was in a lot of pain, and she was ready to even go for amputation because, as you know, there's nothing worse than pain, constant pain. And I am just so glad that we were able to offer her LimFlow, even as compassionate use, and we were able to save her leg at that time, and she continues to do fantastic.
Going from then to now, it's like I don't feel that anymore. I can get up and do things and not think about it. And now my husband and I go places. It's a whole other experience, not having to go through the pain of having the arterial disease in my feet, to be able to walk without pain, and to be able to do the things that I want to do without knowing that I'm going to hurt.
So after we treated Cynthia with the LimFlow procedure, and obviously in short term after the procedure, there's more intense follow-up, right? We want to make sure that we are watching the wound. We want to make sure that there's not a lot of swelling and edema. We want to make sure that the wound is progressing and that we are doing debridement and whatever that's needed to get that wound healed. So there's a little bit more intensity after the procedure. But once the wound starts healing, then it becomes really routine. Now I see, about 2 years out, I see Cynthia about once a year, and she's been doing fantastic. I just saw her in January. As you know, her quality of life is amazing. She has been a star. She has been on many shows. She was on TV here locally. She has helped me with talking to some of our team members here at UH about our limb salvage program. And she also spoke to FDA at some point. So it's been great because I think she can really explain the impact of LimFlow on her, because without LimFlow, she would have been someone with bilateral major below-knee amputation. And most likely she would not be alive today to even tell her story.
When Dr. Shishabor came to my bedside after the procedure, and knowing that how we had talked in his office before and how I had tearfully asked him, please save my leg, I could see that he was hurting, because he had to tell me that there was no hope for that leg. The arteries were too bad. They were really bad. So that was when he came back in, yelling and screaming, so, Miss Elford, Miss Elford. He said, I think I know what I might have for you. It's called a trial study. And he says, if you can hang on, we're going to do this. And I promised him I would.
I have learned, been doing this now about 14, 15 years, working in the area of CLTI, limb salvage, amputation prevention, whatever you want to call it. And what I have learned is that in talking to patients, and as a matter of fact, I remember there was a survey where they asked patients, would you rather die or get amputated? And over 70% of the patients picked dying. Losing your leg is like taking somebody's identity away. It's a big deal. And I think it's very important to the patients. Even though many of them get a prosthetic and are able to walk. But the emotional impact is huge for these patients. So for us, even though the patient may have another leg, we take every leg very seriously. We believe that saving each limb itself impacts the patient psychologically, longevity, and helps them to have a good quality of life. And I think that for people that already have the amputation, major amputation, is even more important, because now they only have one good leg that they can use. Many of these patients use the good leg to pivot, to be able to move to a chair, or to be able to put their prosthetic on, or to get on a wheelchair. So there are so many reasons, to be honest with you, that we have to work hard and give these patients a second option, third option. And I think having the technology and the tools allows us to be able to do that. So at the end, we want to have no limbs left behind. That is our goal. That's our mission.
No limb left behind. And what it means to me is that I can go on. I'm okay with who I am now. And I can do the things I want to do. I just had somebody that I graduated with his sister. And I found out that just not too long ago that he had lost his leg. And he put it off, and I thought for the same thing. And I said, I wish I would have known. I told her I just wish I would have known that I could have gotten the word out to him to call up Dr. Shishabor, see if it would be something that would work for him.
I think the future of LimFlow is going to be very bright, and I've been very fortunate because I've already experienced it. Cynthia's story is an example of one of the patients, but I've had so many patients that I've enrolled into the trial that I've used this technology and we've been able to save their leg. I think there is a lot of hope, not only for the no option patients, which is what we right now are studying and evaluating, but as you know, a significant number of patients don't heal their wounds in a prompt manner. We actually did a study where we showed at 6 months, only 30% of wounds heal that have had successful revascularization using current technologies, either bypass or endovascular. And we hope that as this technology, LimFlow, evolves, not only we are able to take care of patients like Cynthia that was scheduled to undergo a major amputation, but we can use this kind of technology to be able to help heal these wounds faster, so patients can have better quality of life, they can get back to work, they can exercise, and they can enjoy their life without having to deal with their wounds for months and months, as I have described earlier. I'm thinking about my own patients. Many of them have had a number of bypasses. They have had a number of stents. They have had a number of procedures that have failed. And would there be a day that, we will decide based on the anatomy, you know what, this is easy, this is a small wound, we can just fix it with the current technologies, versus, you know what, this is very calcified, this is very difficult, this is going to require multiple repeat revascularization, maybe it's best just to go to LimFlow. And obviously, as the technology evolves and we deal with some of the challenges with the technology, I hope that we will move in that direction. Can it be one day that we can look at the anatomy, and based on the anatomy and the experiences that we have had, we can decide which approach will be best, and rather than having patients go through multiple operations, multiple endovascular procedures, they will go directly to LimFlow and be able to heal their wounds. I'm hopeful, and I think that we will, with the commitment of the company and the field and physicians, we will get there. The other aspect of CLTI patients is that they're from an underserved group of population, and there is significant disparities. We know, for example, that if you have a CLTI and you're African American, you're 4 times more likely to get amputated and 4 times less likely to get revascularization. There's a significant disparity as to who gets CLTI. Many more patients are African American, Hispanics, Native Americans, and many of our patients that come to me, they even have difficulty driving to the hospital to get their wound care. This is another reason that I'm so passionate about this area, because I don't think anyone should lose their leg because of their race or their background or their financial situation. Well, it's very interesting because a lot of people talk about no option patients, and that's a very subjective term in some ways, because it depends on the technical skills that are available in that town, in that area, in that region. So there's particular areas in the country where 25-30% of the patients may be told that there are no options, that there is no bypass, that there is no endovascular. There may be other areas, maybe 10%, because there is very skilled operators that can open up some of these arteries. I would say the safest number is probably around 10 to 15% of patients with CLTI are told they have no options, and they end up either getting amputated or they end up actually dying because they go to palliative care. I myself have had patients in their 80s and 90s because we didn't have LimFlow, we didn't have other options, and because the patient did not want to get amputated, we sent them for palliative care, hospice. They just wanted to die with their leg. They didn't want to live and have an amputation. So it is important when we talk about no option, we understand that it's very variable, but probably the safest number would be around 10 to 15%. But I would say in the United States, probably around 20 to 25%, to be honest with you, because their skill sets vary significantly. There are parts of the United States that endovascular skills are very limited. There are not many people doing endovascular procedures. There are other places in the United States that endovascular skills are very high. There are a lot of operators doing these procedures. So I would say in general, about 15 to 25% of the patients may be told that there are no options, and they either need amputation, they need palliative care, or they may end up in hospice and actually end up dying from the ulcer because they have been told there are no options available. Yeah, I really personally, I work with a lot of new technologies because of my interest in the field and my interest in advancing the field. But I really appreciate companies like LimFlow, because without these innovations, I can't do what I do, which is take care of my patients, help save limbs like I've done with Cynthia and other patients in the last 14 years that I've done my work. So it's great, and I appreciate the FDA, the government, the companies, people in these companies that work hard. It's not easy to bring you an idea, a concept to clinical medicine, to bring it to the bedside. So it means a lot to me, and that's what gives me the passion to work with the companies to bring these technologies to the clinical medicine, to the bedside, so we can treat patients and help them live longer, healthier, and happier. We are very lucky here at University Hospitals because about a year and a half, 2 years ago, we started a program called Limb Salvage Advisory Council. And this was based on our commitment that we want to leave no limb left behind, that mentality, that philosophy of leaving no limb behind. And this program is a multidisciplinary, interdisciplinary program where we have vascular surgeons, interventional cardiologists, vascular medicine, podiatrists, plastic surgeons, all work together in a virtual arena. What happens is that if a patient is deemed that they need a major amputation, this team is activated, the LSAC team, we call it. And virtually, in a very quick manner, we can get on any computer, any iPhone, and the images are shown, the wounds are shown, and we discuss the patient. And if we decide there are options that are still available, we do not allow the patient to undergo a major amputation, and we can save the leg. In the first 6 months of this program, we had 19 patients that were referred for the LSAC. Of the 19 patients, we were able to save 15 legs. These were 15 patients that would have had major amputation, either below knee or above knee, had we had not had the LSAC program. And I think the combination of having limb flow and having this program has been fantastic for us, because a number of those patients were considered for limb flow. So I think there's a good synergy and opportunity for us to work together with the technology and programs like this so that we make sure that no limb is left behind.